Let me take the first of those questions first. So I think the idea of progression just within the central nervous system when everything else is controlled, most people get their head around the fact that you wouldn't want to walk away from a drug in that situation because it's clearly doing some good. So giving a local therapy to the brain, be it neurosurgery or radiotherapy, and keeping the TKI going makes sense. Slightly more controversial is the idea of what happens if that situation arises in the body, what we've called oligoprogressive disease. Everything's controlled, but only one lesion has started to grow. The hypothesis is that acquired resistance is a clonal event. It just starts in one place, and everything else might still be very much asleep under the TKI. And we've shown if you ablate that, for example, with focused radiotherapy, you can buy 4 or 5 months before anything else starts to turn up. What people are now talking about is, well, is that the end of the game? Or well, what if at that 4 or 5 months, it's only one other thing turning up, another clonal event has occurred? Can you repeat that again? And I think you can to a certain extent. When it becomes futile is still trying to be figured out, but the idea of weeding the garden, I think, is becoming much more acceptable. To address your second issue, which what happens when it's more diffuse, I've started to change what I do. I used to stop the TKI, go on to chemotherapy, and then when the chemotherapy stopped working, I would re-challenge with the same TKI, and it was very satisfying to get a re-challenge response. What I've started to do now is actually combine the two, not because I have good data, but theoretically, I think that cancer cells turning over are ways of developing the next mechanism of resistance and the next mechanism. So the more I can suppress every clone, I think theoretically that might be better.
I pretty much adopted the same approach as Ross. A couple of caveats. Oligometastasis you can ablate or you can actually excise, and that has 2 advantages. You're eliminating the local area of progression, maintaining the TKI that's helping elsewhere, and you're also getting a biopsy to really look at the source of the mechanism of resistance. Now, again, maybe that's not going to be operative throughout the tumor, but it'll give you the first hint in terms of other potential therapies that you can use down the pike, whether it's MET or T790. The other caveat, I pretty much adopted the same approach you had in the past, where if they progressed, we stopped the TKI, and I have seen several patients flare at that point, really quite dramatically, and in some cases not recover. So like you, outside of a protocol setting, I'll start chemotherapy. I'll generally continue erlotinib. Do I do it continuously? Do I hold it the day of chemo, the day before, the day after? I think those are still open questions. They're probably not major questions, but certainly practical issues. And of course, like you, and you lead the way in this regard, if a trial is available, I'll certainly preferentially put the patient on that trial if their pace of progression is not too rapid. Yeah. If it's a smoldering but diffuse progression, I feel a bit more comfortable putting them on a second-generation TKI, perhaps combined with another agent that targets MET or that potentially targets T790. But the oligomets, I will almost always continue the erlotinib and deal specifically with each site. And in the case of both EGFR mutation and really ALK translocation, I have seen, like you, patients who've gone on another 4, 6, in one case 18 months without having to really change the main therapy.
I think, I mean, almost the analogy has gone from, it's all or none to, you're in a boat and it's leaking, and if you just keep bailing, the boat's still afloat and you're doing okay.